But today, based on the stack of research you've sent over, we have to look at the heart as something else entirely.
Something biological.
Exactly. We have to look at it as a biological landscape, a terrain. And unfortunately, a terrain that can be invaded.
That is a perfect framing. Because you're right, we tend to romanticize the heart or we mechanize it. But at the end of the day, it is wet, living tissue. It has an inner lining, this very specific, very delicate lining called the endocardium.
The endocardium, okay.
And when that lining gets infected, we are dealing with one of the most formidable, complex, and frankly, dangerous conditions in medicine. Infective endocarditis.
I have to admit, reading through the source material for this one, I got a little uneasy. I think most people, myself included, assume that if you get an infection, you take a pill, you rest for a few days, and, you're fine.
Right. The usual course.
But the language used here, words like fulminating, that doesn't sound like a take 2 aspirin situation.
No, fulminating is a word that should make you nervous. It comes from the Latin for lightning. It implies something sudden, explosive, and destructive. The sources really distinguish between 2 main types of this disease.
2 different paths it can take.
Exactly. You have acute bacterial endocarditis, which is that fulminating presentation. It's a chaotic, high-toxicity event where a patient, and this could be someone who was perfectly healthy just days ago, can die within days to weeks if they aren't treated immediately.
Days to weeks. That's just incredibly fast for an infection inside the heart.
It is. It's a terrifying speed. But then you have the other side of the spectrum, which is arguably just as insidious, subacute infectious endocarditis. This one is described as indolent.
Indolent. That means lazy, right?
In medical terms, it means slow-moving, causing very little pain at first. It, just flies under the radar. This usually happens in people who already have some kind of damage to their heart valves. The infection sort of sets up shop and quietly over months just dismantles the heart's function.
So it's not a blitzkrieg, it's a slow-motion siege.
A slow siege is the perfect way to put it.
Okay, so whether it's a lightning strike or this long, drawn-out siege, what are we actually looking at? What is the enemy here?
The enemy is almost always bacteria. Simply put, infective endocarditis is an inflammation of the membrane lining the heart chambers and, most critically, covering the heart valves, and is caused by microorganisms.
So our mission for this deep dive is to figure out how on earth bacteria get inside the heart, which is supposed to be a closed system, how they survive the incredible turbulence of blood flow, the strange clues they leave all over the body, and finally, the absolute war required to get them out.
And it is a war. The treatment for this is not trivial at all. But to really understand the treatment, we have to understand the fortress that the bacteria build for themselves.
Let's start right there with the mechanics, the etiology. I'm stuck on something basic here. The heart pumps, 60 to 100 times a minute. The blood is rushing through there at a pretty high velocity.
Very high, yeah.
So if I'm a bacterium just floating in the blood, shouldn't I just get washed away? It feels like trying to grab onto a rock in the middle of a fire hose.
That is the central paradox. And under normal circumstances, you are absolutely right. Normal blood flow is laminar. Think of a wide, deep river flowing smoothly. The water moves in these parallel layers. It's gentle on the banks.
Smooth.
The lining of the heart, the endothelium, is designed to be Teflon smooth. Bacteria literally cannot grab hold. They just slip right past.
So a healthy heart is naturally resistant to this kind of invasion.
Highly resistant. But the game changes if you have structural heart disease. Now, imagine you throw a pile of boulders into that smooth river, or you pinch the riverbank so the water has to squeeze through a really narrow gap. What happens to the water?
It gets choppy, you get white water, eddies, chaos.
Exactly. Turbulence. In the heart, if a valve is narrowed, what we call stenosis, or if it's leaky and blood flows backward, regurgitation, you get a high-pressure jet of blood smashing against the heart wall on the other side.
But blood is just liquid. Can it really damage tissue just by hitting it?
Oh, absolutely. The sheer stress from that jet is immense. It's like a tiny pressure walker. That turbulent flow literally traumatizes the endothelial lining. It scratches it. It strips away that protective Teflon layer.
Okay, so now you have a raw spot, a wound basically, but inside the heart.
Correct. And the body, in its attempt to be helpful, rushes to fix it. It deposits platelets and fibrin, which is the sticky protein glue of any blood clot, onto that raw spot. It creates this little sterile thrombus, a tiny scab, essentially.
A sterile scab. So far, so good. It's just healing.
It is, until you introduce the bacteria. And this is where the risk factors really come into play. Let's say this person with the pre-existing valve problem and this little scab goes to the dentist for a cleaning.
Right.
or they have an IV line put in at the hospital, or, and this is a major one, they use intravenous drugs. Suddenly, bacteria from the mouth or the skin enter the bloodstream. This event is called bacteremia.
And now, instead of sliding past that smooth Teflon wall, these bacteria float by and they see this sticky, rough patch of fibrin.
And they stick. It's the perfect anchor point. The bacteria adheres to the platelets in that scab, and once they are attached, they trigger a chain reaction. They cause the body to deposit more fibrin and more platelets on top of them.
They bury themselves. They're building a roof over their heads.
They build a dome. This clump of bacteria, inflammatory cells, fibrin, and platelets is what we call a vegetation.
Vegetation. That's such a passive word. It sounds like moss growing on a rock. But in reality, what you're describing is a bunker.
It is a biological fortress. And this structure, this vegetation, explains everything about why this disease is so difficult to treat. The bacteria are deep inside this dense clot.
So your immune system can't get to them.
Exactly. White blood cells, the phagocytes, which are the soldiers of your immune system, they literally cannot push their way through the dense fibrin mesh to get to the bacteria. The bacteria are completely safe inside.
That is a terrifying thought. You have an active, growing infection in the most vital organ of the body, and your own immune system is effectively locked out.
It's completely shielded.
So who is most at risk for this whole cascade to start? The source material had a pretty clear highest risk list.
It did. The absolute highest risk group involves people who have prosthetic heart valves.
Metal or tissue valves?
Both. Metal and bioprosthetic valves are foreign material, and for some reason, bacteria just love to stick to them. It's a prime surface for them. Also, anyone who has had endocarditis before is at very high risk. If you've had it once, the terrain is scarred, the endothelium is damaged, and you're much, much more likely to get it again.
And what about other things? The list mentioned diabetes, congenital issues.
Right. So congenital heart disease, things like holes in the heart, create abnormal, turbulent flow from birth. Chronic 5A access, like for dialysis or chemotherapy patients, provides a direct highway for skin bacteria into the blood. Diabetes impairs the immune system in general, making any infection more likely to take hold. And then there are acquired issues, like rheumatic heart disease from an old strep throat, or even a very common condition like mitral valve prolapse.
Let's talk about the IV drug connection for a second. The sources were very specific about that being a major pathway.
It is, and it presents in a very distinct way. When someone injects drugs intravenously, they're often using non-sterile needles or substances, and they're introducing aggressive skin bacteria, like Staph aureus, directly into the veins.
And the veins all lead back to the right side of the heart first.
Exactly. The bacteria-laden blood comes back from the body, and the first door it sees, the first valve it hits, is the tricuspid valve. So in 5V drug users, we disproportionately see right-sided, or tricuspid valve, endocarditis.
And what does that mean for the patient?
Well, because the venous blood goes from the right heart straight to the lungs to get oxygenated, these patients often present with what we call septic pulmonary emboli. Chunks of that infected vegetation break off, travel into the lungs, and cause pneumonia or abscesses. It's a very different picture than left-sided endocarditis.
What a nightmare scenario. Okay, so we know the terrain, we know how the fortress is built. Let's talk about the invaders themselves. The source is focused on a big three.
Right. If you're going to get endocarditis, it is overwhelmingly likely to be caused by one of three groups of bacteria: Staphylococcus, Streptococcus, and Enterococcus.
Let's start with the bully on the playground, Staphylococcus.
Staphylococcus aureus. This is, without a doubt, the heavyweight champion of endocarditis. It accounts for anywhere from 30 to 70% of cases. And I call it a bully because, unlike the others, Staph aureus doesn't necessarily need a pre-existing heart condition.
Wait, I thought you just said we needed that turbulence, that little scab for the bacteria to stick.
For most bacteria, yes. But Staph aureus is different. It is so virulent, so aggressive, it carries specific surface proteins that allow it to latch onto even intact, healthy endothelium. It can invade a perfectly normal heart.
So it brings its own lock-picking kit?
It doesn't even pick the lock. It blows the door off the hinges. And once it's there, it produces enzymes and toxins that destroy tissue rapidly. This is the bug that's almost always responsible for that fulminating acute presentation we talked about.
So staph is the SWAT team. Then we have the second group, Streptococcus.
Specifically, the viridans group Streptococcus. These are the guys that live in your mouth, in your oral flora. They are much, much less aggressive than staph. They are the true opportunists.
So they do need that pre-existing damage.
Absolutely. They generally cannot attack a healthy valve. They need that turbulent flow, that little fibrin scab we talked about, to get a foothold. This is the classic cause of the slow subacute endocarditis that might smolder for months after, say, a dental procedure.
And the third group, the enterococci.
These are gut bacteria. They inhabit the gastrointestinal tract. They account for maybe 5 to 18% of cases. Now, they aren't as outright destructive as staph, but they are incredibly stubborn. They are naturally resistant to many common classes of antibiotics, which makes them very hard to clear. Think of them as the tank, hard to destroy.
The destroyer, the opportunist, and the tank. A lovely bunch.
And there are others, of course. Fungi, rarer gram-negative bacteria, but those three are the main players.
Okay, let's move to the detective work. Because the symptoms listed in the source material, honestly, they sound like everything and nothing all at once. Fever, chills, weakness, night sweats, weight loss. If I have those symptoms, I assume I have the flu.
That is the danger. And it's why the diagnosis can be delayed. We call endocarditis the great imitator because it can mimic so many other systemic illnesses. A fever is the most common sign, present in over 80% of patients, but a fever can be anything.
It's complete and nonspecific.
Completely. However, there is one pairing that makes a doctor's ears perk up immediately. One clinical sign that is a huge red flag. Fever, plus a new heart murmur.
The sound of the turbulence.
Exactly. If you put a stethoscope on a patient's chest and you hear a whooshing or rumbling sound that wasn't there on their last exam, or a known murmur that has suddenly changed its character, that tells you something is physically disrupting the blood flow across a valve.
So the vegetation is getting big enough to block the flow, or maybe it's eaten through the valve so it can't close properly.
Precisely. It's an audible sign of structural damage. But then, and this is the part that I found most fascinating visually when I was learning this, there are these stigmata. The bacteria leave these strange clues on the skin, far, far away from the heart.
Right, the peripheral manifestations.
These are classic signs. They appear because the vegetation, that bacterial fortress, is friable. That means it's crumbly, it's unstable. Little bits of bacteria and clot can break off and get shot downstream into the circulation. Yes, septic emboli. Or, in some cases, the body's immune system creates these clumps of antibodies and antigens that get stuck in tiny blood vessels. Let's start with the hands. You have Osler nodes and Janeway lesions.
Okay, how do you tell them apart? They both sound like red spots.
They are, but with one crucial difference. Osler nodes are typically on the pads of the fingers or toes. They are raised, reddish-purple bumps, and the key is they hurt. They are tender to the touch.
Painful. Why? What's causing the pain?
It's believed they're caused by immune complex deposition. It's an inflammatory reaction in the walls of the tiny blood vessels. It involves nerves, so it's painful. Now compare that to Janeway lesions.
Go on.
These are flat, irregular red spots we call the maculae on the palms of the hands or the soles of the feet. And the key here is they are painless.
Painless spots on the palms.
Right. And the reason they're painless is because they are different phenomena. Janeway lesions are basically microabscesses caused by septic emboli, tiny clumps of bacteria getting stuck in the capillaries of the skin. They don't have that same intense, painful, inflammatory response.
That is such a specific and weird distinction. Painful bumps on your fingertips, painless spots on your palms, and then there are the fingernails themselves.
Splinter hemorrhages. If you look at the nail bed, it looks quite literally like you shoved a tiny wood splinter under the nail. These dark, linear streaks. Again, this is caused by tiny clots or emboli damaging the capillaries that run vertically under the nail.
It's incredible that the body broadcasts a central heart infection through the fingertips. And there were others, right? Roth's spots.
Yes, Roth's spots. You need an eye doctor to see these. They are hemorrhages in the retina, in the back of the eye, that have a pale center. Another sign of embolic or immune damage. And finally, clubbing of the fingers, where the nails start to curve over the fingertips, can be seen in long-standing subacute cases.
Okay, so you see some of these signs, you hear a new murmur. Obviously, you can't just look at someone's hand and say, yep, heart infection. You need hard proof. How do we confirm it?
You need to do two things. Catch the bacteria in the act and see the fortress. Step one is blood cultures. Because the vegetation is constantly shedding bacteria into the bloodstream, endocarditis causes what we call continuous bacteremia.
So it's not like a spike of bacteria and then it's gone. It's a constant low-level stream.
A constant stream, exactly. So we don't just take one blood sample. The classic teaching is to take 3 sets of blood samples from different parts of the body over a 24-hour period. In over 95% of cases, we will grow the organism and identify it.
And then step 2, you need to see the fortress.
We need to see the vegetation. For that, we use echocardiography.
The ultrasound of the heart.
Yes, but here's a critical nuance the source emphasizes, and it's a huge deal in practice. We have two main types, TTE and TE.
Transthoracic and transesophageal.
Right. TTE is the standard one, the wand on the chest. It's non-invasive, it's easy.
Yeah.
But it's not great for this.
The sensitivity numbers in the notes were shockingly low, like what, 60%?
Around 58 to 63%, depending on the study. Think of TTE like trying to look into a room through a frosted glass window. You can see movement, maybe some large shapes, but you're going to miss the details. The ribs and lungs get in the way. If the TTE is negative, but you still highly suspect endocarditis, you cannot stop there.
You have to bring out the big gun, the T.
Transesophageal. We pass a small ultrasound probe down the throat into the esophagus, which sits directly behind the heart. There are no ribs, no lungs interfering. It's like opening the door and walking right into the room. The picture is crystal clear.
And the sensitivity is much higher.
It jumps to over 90, even 95%. With a T, we can see vegetations as small as a couple of millimeters. We can see abscesses. We can see holes in the valves. It is the gold standard for visualizing the damage.
So we have the cultures, we have the pictures from the echo, and then we combine all this information using something called the Duke criteria to make the final diagnosis.
Correct. The Duke criteria is basically a scoring system. It has major criteria, which are the big ones, positive blood cultures for a typical organism, or evidence of a vegetation on an echo. And then minor criteria, things like fever, IV drug use, those vascular phenomena like Janeway lesions. You need a certain combination to formally classify it as definite endocarditis.
Okay, we found the enemy, we know where they are. Now begins the siege. The treatment section of these notes was intense. It seems like the standard rules of antibiotics just don't apply here.
They don't, and it all goes back to that fortress concept, the vegetation. Remember, the bacteria are encased in layers of fibrin. There are no blood vessels that penetrate inside of vegetation, so the antibiotic can't be delivered directly by the blood to the bacteria.
It has to soak in from the outside.
It has to passively diffuse to soak through the layers of the clot to reach the bacteria hiding in the center.
So you need massive amounts of the drug just to get a little bit to the target.
Extremely high doses. And you need it for a long, long time. This is why the standard treatment duration is 4 to 6 weeks. We have to maintain high concentrations of the antibiotic in the blood for over a month to ensure enough of the drug seeps into the very core of the vegetation to sterilize it.
And you mentioned something earlier about the state of the bacteria deep inside. They aren't exactly partying in there, are they?
No, that's another huge problem. Deep inside the vegetation where there's not much oxygen or nutrients, the bacteria are often metabolically inactive. They're essentially dormant. They're not replicating quickly.
And that's a problem because
most of our best antibiotics, especially the penicillins, work by disrupting the bacterial replication process. They attack the cell wall as it's being built. If the bacteria aren't actively building their walls, the drugs don't work nearly as well.
So they're hibernating, which makes them much harder to kill.
Exactly. That is why we must use bactericidal drugs, drugs that actively kill the bacteria, whether they're dividing or not, rather than bacteriostatic drugs, which just stop them from growing and let the immune system clean up the mess. Here, the immune system can't help us, so the drug has to do all the killing, and it all has to be given intravenously.
Right, no pills for this.
0 pills. You need that high, continuous blood level that only IV administration can provide.
Let's look at the specific battle plans, because the strategy changes completely depending on who the invader is. Scenario A. The streptococci, the mouth bacteria.
Right, the viridans strep. This is generally the best case scenario for endocarditis, if there is such a thing. These bacteria are usually very sensitive to penicillin. The standard old-school plan is high-dose penicillin G, given intravenously for 4 weeks. Or a more modern approach is ceftriaxone, which is easier because it's once a day.
But I saw a shortcut mentioned in the notes, a 2-week option. That seems like a huge difference.
It is, but it's only for a very specific, low-risk group of patients. We can shorten the war to 2 weeks if we use synergy.
Synergy. This is the classic 1-2 punch.
Exactly. We combine the cell wall agent, penicillin or ceftriaxone, with an aminoglycoside antibiotic, usually gentamicin. Now, normally, gentamicin struggles to get through the thick cell wall of a strep bacteria. It sort of bounces off.
Okay.
But penicillin's job is to inhibit cell wall synthesis. It basically punches holes in the wall.
So penicillin breaches the wall, and gentamicin runs in behind it.
Precisely. Penicillin opens the door and gentamicin rushes in and destroys the protein-making machinery, the ribosomes of the cell. Together, they kill the bacteria much, much faster than either could alone. But again, we only do this for very straightforward, uncomplicated cases on a native valve with small vegetations.
Got it. Okay, scenario B, Staphylococci. Staphyl aureus, the destroyer.
This is a much harder fight. If the staph is sensitive to methicillin, what we call MSSA, the drug of choice is a potent anti-staphylococcal penicillin like nafcillin or oxacillin for a full 6 weeks.
Now, I need you to explain something that seems backwards to me. In the popular imagination, and even in a lot of hospitals, vancomycin is seen as the big gun. It's the heavy artillery for staph. But the source material says that for MSSA, vancomycin is actually inferior.
This is a crucial, crucial point, and it's one of the biggest takeaways for anyone in medicine listening. For MSSA, if the patient is not allergic, vancomycin is the wrong choice.
Why? I mean, it kills staph. Why is it worse?
It's all about the speed of the kill and the mechanism. Nafcillin is a beta-lactam. It binds to the proteins the bacteria use to build their walls, and it causes them to lyse to burst very, very rapidly. It is a sledgehammer. Vancomycin is a massive, bulky molecule. It works by wrapping around the building blocks of the cell wall to stop construction from happening. It's slower. It's like slowly picking away at a brick wall versus blowing it up with dynamite.
So if you use vancomycin on a bug that nafcillin could kill, you are deliberately choosing a slower, less effective weapon.
And in a disease like endocarditis, where tissue is being destroyed by the hour, speed matters. Studies have consistently shown that for MSSA endocarditis, patients treated with vancomycin have higher rates of treatment failure and persist with bacteria in their blood longer than those treated with nafcillin.
So you save vancomycin for when you have no other choice.
You save it for MRSA, the methicillin-resistant staph, because nafcillin simply doesn't work on those. For MRSA, vancomycin is the go-to. Daptomycin is another alternative if vancomycin fails or is toxic.
Okay, that makes sense. Use the sledgehammer if you can. But what if the staph is on a prosthetic valve? The nightmare mode we talked about earlier.
Prosthetic valve endocarditis, or PVE, is a different beast because of one word: biofilm.
Biofilm.
When staph grows on a foreign material like metal or plastic, it secretes this protective slime layer, a polysaccharide matrix. This biofilm is incredibly resistant to antibiotics. Most drugs just can't penetrate it.
So the fortress has a force field now.
Essentially, yes. To break it, we need a triple drug threat. We use vancomycin to cover for the high likelihood of MRSA in a hospital setting. We use gentamicin for that synergistic killing effect. And we add a third, very special drug, rifampin.
What's special about rifampin?
Rifampin is unique because it can penetrate that biofilm. It can soak right through the slime and kill the dormant bacteria that are adhering directly to the metal or plastic of the valve. It is absolutely vital for curing prosthetic valve infections.
But there was a huge warning about it in the NITES.
The massive one. Bacteria develop resistance to rifampin almost instantly if you use it by itself.
So you can never, ever use it solo.
Never. You have to use the other drugs like vancomycin and gentamicin to keep the overall bacterial population down while rifampin does its specialized sniper work on the biofilm. It's a coordinated attack.
That is incredibly complex coordination. Okay, finally, scenario C, Enterococcus, the tank.
Enterococcus is a naturally tough bug. For one, it's intrinsically resistant to an entire class of antibiotics, the cephalosporins. You can pump a patient full of ceftriaxone, and the Enterococcus won't even blink. And they are only inhibited, not killed, by penicillin or ampicillin alone.
So we're back to synergy again.
Mandatory synergy. You must combine a cell wall agent like ampicillin with an aminoglycoside like gentamicin to get a true bactericidal effect. If you don't use both, you are just stunning them, not killing them. And in endocarditis, stunning the enemy is a losing strategy. It's a 4 to 6 week course of that combination therapy.
We've talked a lot about chemical warfare, but sometimes the drugs just aren't enough. The fortress is too strong, or the heart itself is crumbling under the attack. We have to talk about surgery.
This is often the moment of highest tension in managing endocarditis. The decision to take a critically ill, infected patient to the operating room. Remember, the heart tissue is infected. It's inflamed, it's friable, meaning it tears easily. It doesn't hold stitches well. It is an extremely high-risk surgery.
So it's a last resort.
It can be, but sometimes it is the only way to save the patient.
So what forces that hand? When does the medical team look at each other and say, the antibiotics aren't working, we're going in?
The number one most common reason is the development of heart failure. If the infection has literally eaten a hole in a valve leaflet or destroyed the cords that hold it in place, the valve becomes massively leaky. The heart can't pump effectively. Fluid backs up into the lungs. The patient is, for all intents and purposes, drowning. No amount of antibiotics will fix a mechanical hole.
Mechanical failure requires a mechanical fix. You have to replace the part.
Exactly. You have to go in, cut out the infected valve and all the surrounding infected tissue, and sew in a new prosthetic valve. Another absolute indication is an abscess. Sometimes the infection burrows out of the valve and into the heart muscle itself, forming a walled-off pocket of pus. Antibiotics cannot drain an abscess. You have to surgically cut it out.
The notes also mention kissing lesions. That sounds weirdly romantic for something so gross.
It's a visual description from an echocardiogram. Imagine a large, floppy vegetation on a mitral valve leaflet. Every time the heart beats, that vegetation swings across and hits the opposite leaflet. It kisses it. Eventually, the infection spreads to that side too. If you see that happening, or if the vegetation is just huge over a centimeter and threatening to break off and cause a massive stroke, you operate.
So it's a race against time. You're trying to sterilize the infection with drugs, but if the heart starts falling apart mechanically or threatening a major complication, you have to switch tactics and go to surgery, even if the infection isn't fully treated.
That's the dilemma. And sadly, mortality remained high, especially when certain factors are present. Fungal endocarditis, for instance, almost always requires surgery because antifungal drugs just can't penetrate the vegetation well enough to cure it.
Let's zoom out for the final section, prevention. We've all been there, sitting in the dentist chair, getting our history taken, and they ask, do you have a heart condition? Do you need to take antibiotics before we clean your teeth?
The dental connection. And this has been a topic of huge debate and change in the medical community for decades.
Why the debate? On the surface, it seems so logical. Mouth bacteria cause endocarditis, the dentist stirs up mouth bacteria, so you should give antibiotics. Simple.
It is logical on the surface, but here's the reality that researchers discovered. You get transient bacteremia, a temporary shower of bacteria in your blood every single time you chew food, every time you brush your teeth vigorously, every time you floss.
Wait, really? So I could have bacteria in my blood right now just from having lunch?
It's very likely, yes, for a few minutes anyway, and then your immune system efficiently cleans it up. The point is, the cumulative exposure to oral bacteria from just living your life chewing, brushing day after day is thousands of times higher than the exposure from a single 30-minute dental cleaning every 6 months.
So focusing on that one dental visit with a single pill? It's like trying to stop a flood with one sandbag. It might not actually be doing much.
Exactly. And you have to weigh that tiny potential benefit against the real risks of antibiotics. They cause allergic reactions. They can cause severe diarrhea like C. diff. And, most importantly, overuse of antibiotics breeds resistance in the community. So, the guidelines shifted dramatically.
From what to what?
We used to give antibiotic prophylaxis to almost everyone with any kind of murmur. Mitral valve prolapse, trivial leaks, you name it. Now, we've realized the risk of the drug actually outweighs the benefit for most people.
So who still gets the pill? Who is it worth it for?
Only that highest risk category we mentioned way back at the start. If you have a prosthetic heart valve, if you've had endocarditis before, if you have certain types of unrepaired cyanotic congenital heart disease, the so-called blue babies, or if you've had a cardiac transplant and developed a valve problem. That's pretty much it.
So for the vast majority of people with a common benign murmur or a mitral valve prolapse, the new rule is no meds before the dentist.
Correct. The guidelines are very clear now. And they emphasize that good daily oral hygiene, brushing, and flossing is actually the best prevention for endocarditis.
Right.
Far more important than a single dose of antibiotics at the dentist.
That makes perfect sense. Keep the baseline bacterial load in your mouth low every single day. But for that small, high-risk group, what is the actual protocol?
It's very simple. 2 grams of amoxicillin taken as a single dose by mouth, about 30 to 60 minutes before the procedure.
Just one dose. That's it.
Just one. The goal is to have peak antibiotic levels in the blood right at the moment the dentist is manipulating the gums and potentially causing bacteremia. If they're allergic to penicillin, we use other drugs like clindamycin or azithromycin.
It's amazing how much science and debate there is behind that one little pill.
It's a risk-benefit calculation that took us the better part of 50 years to really refine.
So bringing this all together, we've looked at the heart not just as a mechanical pump, but as a vulnerable biological landscape. We've seen how turbulent blood flow can act like a river carving a canyon, creating a foothold for bacteria where there shouldn't be one.
We've seen how those bacteria then co-opt the body's own healing system to build a fortress, a vegetation that keeps the entire immune system out which in turn necessitates this massive chemical siege with weeks of high-dose 5E antibiotics.
We've learned that these strange, almost archaic-sounding sign spots on your palms and splinters in your nails are actually modern-day distress signals from a heart under direct attack. And we've learned that the choice of weapon, that distinction between nafcillin and vancomycin, can be the difference between success and failure.
It really, really highlights the incredible resilience of these microscopic organisms. I mean, think about it. A bug like Staphylococcus or Enterococcus can survive inside a dense fibrin clot, completely immune to our white blood cells, evolving resistance to our best drugs, all while hiding in the most turbulent, high-pressure, high-velocity environment in the entire human body.
It is humbling. We have all this incredible technology, transesophageal echo, open heart surgery, advanced pharmacology, and yet we are still locked in this desperate, weeks-long battle with a single-celled organism that just found a good place to stick.
That is the eternal struggle of infectious disease, isn't it? The bacteria adapt, they persist, and they exploit any and every vulnerability in our own biology. Our job is to stay vigilant, to understand these mechanisms inside and out, and to know exactly when to bring out the sledgehammer.
And for you listening, knowledge is your own form of prophylaxis. Knowing your own heart history, understanding why the dentist asks those specific questions, that puts you in control. It's your first line of defense.
Absolutely. Stay curious and stay vigilant.
Thanks for diving deep with us today. We'll see you next time.